20 years ago, we discovered a molecule that we now know as PD-L1, and that's become the key to the new strategy of immunotherapy. The PD-L1 molecule is used by tumors to turn off the immune response. Immunotherapy tries to activate the immune response to attack the cancer cell, and that's a tremendously powerful fighting force. Immunotherapy brings greater benefit to patients. They survive longer.
In 2012, I was diagnosed with stage 3B lung cancer.
August of 2017, my one-year scan showed that my cancer was back.
And he said I had less than 6 months to live. So I came to Dana-Farber.
If you block that PD-L1, that allows the immune system to see the tumor and attack it.
Received the chance to get into this trial with PD-L1. We jumped at it.
After 3 treatments, my tumors had shrunk 25%.
And then after 3 months, I had clear scans again, and then 3 months, clear scans again.
People everywhere get cancer. The PD-1 and PD-L1 drugs are now accessible to patients around the world.
1 week you're making out your will. The next week you're celebrating life. It's unbelievable. Unbelievable.
It's wonderful. I'm here, almost 8 years later, because of that.
My mom did cry, and my dad, and everyone.
PD-L1 saved my life.
Saved my life.
What we do here at Dana-Farber changes lives everywhere.
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 Hi, I'm Eric Weiner from Dana-Farber Cancer Institute, and I'm joined by a group of my colleagues who I'll introduce in just a minute. Just a few words about Dana-Farber. Dana-Farber is in Boston, Massachusetts, and is an institute that is equally split between clinical care and research. We have a mission that is very much devoted to patient care, as well as a mission that is focused very, very clearly on trying to make care better in the future, to try to relieve the suffering from cancer that we know will happen in the years ahead if research does not occur. We are committed to multidisciplinary care, and we're committed to taking care of patients across the continuum and all patients. We work very closely with Brigham and Women's Hospital, our partner in taking care of adults with cancer. And for pediatric oncology, and you'll hear more about pediatric oncology a little bit later from one of my colleagues, we partner with Boston Children's Hospital. We've been quite committed to international patient care, particularly care of patients from the Gulf states in recent years. We have a large international program. We see many patients from around the world, and again, particularly from the Middle East. And we also have relationships with a number of medical centers around the world. This is something for us that is a commitment that will continue to grow in the future. Despite what's happened with COVID, and I'm sorry to say we're all too familiar with that, we've been able to continue to deliver what we view as essentially the same care. In fact, there have been lessons we've learned from COVID that we'll take forward when at some point in time we're past COVID. And although for a while we were not seeing hardly any international patients, our International Patient Center is now up and running once again. We have specialists, both a physician and a nurse in oncology who work in that center and who try to make those consults that we see, or patients who come for continuing care, to try to make it as easy as possible. We also have the availability of video conferences and telephone consults for those patients who simply cannot come. So that's the background. We want to touch on a number of subjects and then open this up to questions. I'm joined today by three colleagues. The first person you'll hear from is Ann Gross, who is Senior Vice President for Patient Care Services and Chief Nursing Officer. You will then hear from Leslie Lehmann, a pediatric oncologist who's the clinical director of pediatric stem cell transplant and the medical director of the Dana-Farber Harvard Boston Children's Global Health Initiative. And finally, you will hear from Nancy Borstelmann, who is the Senior Director of Social Work, and she will touch on the impact that COVID has had on the lives of our patients and their families from a psychosocial standpoint. So before going any further, let me turn this over to Ann. And I'm actually going to come back to Ann later to talk about nursing. But I wanted to start off asking you if you would talk a little bit about what those first few weeks were like when we realized that we were dealing with this pandemic, what we as an institute did to try to get ready, or more than get ready, dramatically change our entire processes, and how that's gone over the past several months. Ann? You're on mute.
Thank you, Eric, and hello, everyone. It's a pleasure to be here and share some of our learnings with you over the past 6-7 months. As I'm sure you know, here in Boston, we early on were headed toward being a rather big hotspot in the COVID pandemic in the US, and it happened pretty quickly. Once the first cases came out of a big biotech conference that was held here in Boston, we knew that we needed to act very rapidly because of the way this virus was spreading in our community and in the city in general. So by the beginning of March, we were developing a plan that we implemented within days to put everyone, as many people as we could, off-site, working remotely, and keeping only on-site our employees who were needed to treat patients. Our overarching aim all throughout, and it continues today, is to keep our patients safe, to keep our staff safe, and to continue to provide the life-saving cancer care that our patients need. Of course, you know, we've said this a lot in the last months that, you know, our cancer doesn't stop for COVID, and neither can we. So how could we, the big question we were facing was, how could we continue to provide care that our sort of philosophy and model of care is very much grounded in relationships amongst the team members, very solid relationships with patients and families. And so how could we do that while everything else that we had to do to respond to the pandemic and to the virus and to keep people safe and mitigate transmission was pushing us all away from each other, you know, both physically and with all sorts of barriers of personal protective equipment and so on. And so we really tried to keep those core principles of who we are as a cancer institution at the heart of every decision we made. So we had to make this decision to work remotely, to keep anyone and everyone out of our buildings that we possibly could, so that we could continue to provide safe care in person to those who needed it. The other thing, and you know, particularly to the US, we were very challenged with personal protective equipment supply. The national supply chain was not able to respond, and we very, very early on put a big team together to assure from all kinds of traditional and non-traditional methods to assure that we could have the right supply of personal protective equipment on hand throughout. And I am happy to say that we were never in a position where we didn't have that. And we felt like that was so key we were asking so much of our clinicians, putting themselves at risk on the front line. We had to have the supplies there for them. And I have to say, that could be the subject of a whole nother talk, how many different avenues and people that were involved, including our board and many people, to assure the supply of PPE. We had to set up several different kinds of operations that everyone had to do, screening patients and staff at the front doors. We did a lot of innovative things. We certainly are an institution where we are training the next generation of a lot of different disciplines. And so for our nursing students, we quickly reassigned them to assist us at the entry points where we were screening every single staff person that came in every day for symptoms of COVID, and every patient that had to come in for care. We made a very, very painful decision of eliminating any visitors coming with patients, and so we had to escort many of our patients to their appointments. But we really felt, again, although we normally under our regular operating circumstances have all sorts of family members, the whole family, if they want to be there, come to an appointment, we really had to curtail that during this time. But we've used all sorts of technology and other innovative strategies to bring the family members into the room and bring them to the bedside to be with patients digitally instead of being actually physically present. Another thing I would say is that we also felt it extremely important to remain connected as a team, as team members, as an institution. We were not an institution that was working remotely or doing telehealth visits until this time. And so we've put into place a number of strategies. We have our president hosts at the time it was a weekly forum that with different leaders in the organization giving updates to all of our staff, our board members, people in the community, about just keeping people aware of what was going on. As everyone knows, policies and standards and things were changing almost daily, and we really looked for ways that we could keep people connected. As I said, we moved to remote work, and I think others will talk about this, the telehealth visits, and put into place a lot of ways, telephone hotlines for staff and providers to call into to get the latest information about testing or symptoms that were added to our screening process and so on. And then finally, I'll just say one of the other sort of core missions at Dana-Farber is the conduct of clinical trials and the really commitment to discovery. And so we worked very hard to maintain all of our clinical trials that we had open and accruing patients, to maintain them running fully while during this pandemic. And it really took some very innovative strategies by our research pharmacists and pharmacy techs and research nurses. We also had a lot of students in there that came together and put an entire system in operation together of shipping research, the drugs, investigational drugs that are oral agents to patients at their homes so that they continue to be on the trial without having to come in, because as we treat a number of patients who don't live in Boston, and so how could we, they put this whole system together to make sure that those patients could stay on their trial and receive the drugs through shipment. And then, of course, we had nurses and clinic assistants and some physicians on site to continue treating patients that needed to be treated with infusional therapy or things like radiation therapy. So I think I'll stop here, and unless Eric, you want me to.
I'm going to circle back to talk more about nursing in just a few minutes. So next, we're going to hear from Leslie Lehmann. Again, Leslie is a pediatric oncologist who directs our pediatric stem cell transplant program. And Leslie, if you could talk first about the general approach in pediatric oncology as a consequence of COVID, whether that changed at all, and then more specifically about BMT and COVID.
Thank you. Thank you for inviting us. It's an honor for sure. So, you know, we in pediatrics have a unique spot. Our inpatient is at Boston Children's Hospital, but all of our outpatient care is at Dana-Farber. And so we really try to work seamlessly as one team, but very early on, we realized that there were some things that would pertain to children that were different from adults, but as much as possible, we wanted the practices to be seamless across the age continuum to sort of decrease confusion and to send the same messages. And so everything that Ann Gross said, we adopted very early on, employee screening, getting enough personal protective equipment around, symptom screening for patients, and all of the expected things. One of the ways that we were different generically in pediatric oncology is that we had to allow an adult to come with the children. So it's impossible not to have visitors, and we basically limited it to one visitor, one guardian bringing the child to the appointments. Try to have it be the same guardian as much as possible, guardian or parent, and did symptom screening for those people. But you by the nature of pediatrics, we had double the number of people coming through our clinic per patient as the adult people would. The other thing we learned really early on is that this is a multidisciplinary approach, and we had so many meetings with nursing, with environmental services, with pharmacy, with sort of the administrators who are managing patient flow, just to make sure that everybody had a voice, everybody's concerns were taken into account for the final product, and that this was really, again, a consensus opinion that we were doing going forward. It was very hard in the beginning because as the information grew, the rules would change, and we'd been through several iterations of rules as you sort of would expect. Moving on to transplant, I think the main problem with transplant, and this is speaking broadly for both pediatric and adult transplant because we worked very closely together, is that transplant is a global thing, number one. And number two, transplant has yet another group of people because it has the donors involved in the vast majority of the patients. And so, we use donors from throughout the world through the National Marrow Donor Program, and managing how you would have those donors come, you would have those donors harvested, how you would make sure.
Hopefully this is a brief internet challenge. We'll wait another couple of minutes or a couple of seconds before moving on. Leslie, I don't know if you came up with, sorry? No. You froze for about 30 seconds.
Okay, sorry. So the organizations that run bone marrow transplant in both America and Europe, the EBMT and the ASTCT, came up with guidelines within 2 weeks of the pandemic really becoming a factor. And those guidelines talked about patient screening and about donor screening. And we, of course, implemented those guidelines as a baseline and then added in things that we would need on top of that. And so every patient needed to be tested before transplant workup started, and every patient needed to be tested within 48 hours of actually coming into transplant. And then the donors needed to be screened at the time of harvest as well. The regulatory agencies and the National Marrow Donor Program suggested that all the products initially be frozen. And I think the other thing we learned through COVID is how the whole systems are so interconnected that when you make a change in one, it ends up having very unforeseen downstream effects. And so the recommendation was that before you start giving the patient chemotherapy, that you had the product harvested and frozen in your in your facility. And that was safe for sure, but ended up doubling the work of our cell processing lab, which was very difficult. And then as more data came out, also for some diseases ended up not having the product be actually as good. And so it's been an iterative process. And now for bone marrow failure syndromes, we take the product fresh, and that has its own set of problems. And for most others, we're still taking products frozen. Because of that and the difficulties in knowing about donors, virtually every program in America canceled non-urgent transplants. So the transplants for leukemia still went on, and the transplants for lymphoma, but transplants for sickle cell disease or some bone marrow failure syndromes or even multiple myeloma for the adults tended to be delayed so that we could do it in the time that was the most safe. And then, as Anne alluded to, we're a research institute, and all therapeutic research trials were put on hold as well. So I think for me, the biggest take home really has been that, COVID came and we wanted a plan. And I think we all got a little frustrated that the plan kept changing, but of course, COVID kept changing. And so we ended up having a good, cohesive working team, and we had plan A, but then we went to plan B, plan C, bringing many things from the previous plans, but then actually, taking the new information in and making the plan again, implementing it, disseminating this information, and then going on in a sort of continuous quality improvement kind of style. So I'll stop there.
So before you stop, though, if you could also perhaps comment just briefly about how your group makes this work for international patients, particularly patients from the GCC, both with regard to making the whole continuum of care as accessible as possible to people, because obviously people from any part of the world, or specifically the GCC, aren't going to come to the United States and move there for the rest of their lives. They need to get some care back at home, and as part of that, what you've done in terms of these tumor boards that you've conducted.
Exactly. So we've had a large international population in bone marrow transplant now for many years, and I've been to the Middle East extensively working with the longitudinal partners on the ground. And so when COVID first hit, it was terrible. People couldn't come to us, and patients couldn't get home. I think it's fair to say, sort of egocentrically, we hadn't realized that many of the Gulf states weren't comfortable sending their patients to America when we were having such high COVID infection rates. And the rates were lower in the Middle East for a long period of time. But now the restrictions have been lifted for medical patients, and we're beginning to both take patients and send patients who have completed treatment home. But the end goal for all, I think, international patients is to capacity build on the ground so that ultimately the most cutting edge therapies you may come to the Dana-Farber for, but for the routine therapies or the evolving routine therapies that we have worked with partners and made it easier for them to deliver the care or a big part of the care in the home country. For that to happen, the physicians on both sides of the ocean have to really know each other, trust each other, just like you would with colleagues that were down the street. And so we're starting, especially in this time where I used to go to the UAE and Kuwait 3 or 4 times a year. And that just has been increasingly difficult with COVID and travel bans from the US and from institutions. So we're starting a tumor board where every month we have about 10 different institutions represented from around the Middle East, and myself and the big pediatric hospital in Egypt. And we discuss, and people take turns bringing difficult cases. We discuss those cases, and then patients that we have transplanted and sent back to UAE, Kuwait, Saudi, then we can actually discuss those specific patients and try to do a long-term follow-up. I'm also working on an initiative through WBMT, the World BMT Institute, to send out a survey to all of our partners in the Gulf about what the obstacles are to caring for patients that were transplanted in the Northeast or Europe and then transitioned back to home.
Thanks. Nancy, so it's almost unheard of for a patient to be diagnosed with cancer without experiencing some amount of anxiety or other symptoms. Now, of course, that can, in some in some individuals be much more severe than a little bit of anxiety. And COVID, if anything, has not helped that. Superimpose on that the patient who's coming from a different country who doesn't speak English and has found her or himself being taken care of in Boston. Just wondering if you can comment both generally about our patients and then more specifically about our international patients in terms of the challenges that they have faced over the past few months and what the psychosocial group, which is for us, social work, psychiatry, and psychology, what all of you have done to try to help with that. You're on mute.
Okay, got it. All right, thank you. Thanks, everyone. It's a pleasure to be able to talk with you all this morning. So as Eric was noting, having a cancer diagnosis itself, of course, is a life-changing event. And the levels of distress can be ranging from, what you would expect, normal feelings of worry and sadness, to really almost disabling anxiety or depression. And depending on what life you have been living before you even had cancer, there may be other factors that make it more difficult for you and perhaps for your family, whether you're a low resource family, whether you have difficulty just managing in the world as it is, if you don't have a good job, if you're not paid well, all these factors can really come into play. And now for our patients having to manage through COVID, with additional uncertainty on top of that, which you already have to live with cancer, I think we were really taking a big step back and saying we have to be as close and even closer to our patients at sort of paradoxically at a time when we are all separated. And I think as Anne was commenting, we are a relationship-based practice in clinical social work, but also my colleagues in psychology and in psychiatry. So how are we going to provide care? And initially we had to transition our entire workforce, both on our main campus in Boston, but also on our satellite sites, to be working remotely, to bring your laptop home, take a few folders. We have to be off site. And I think one of the things that I learned through all of this is the incredible resilience of people, that no longer are you going to be working the way you usually work. You're going to have to relearn how do you manage your day. And while we're doing this, we're also looking at our patients and their family members who are also living this in their own way. So I think one of the things that we learned early on was we had to do a few things. We had to think about how to be as connected as possible. We had to get our mechanisms set up for telehealth so that rather than meeting with patients in infusion or in consult rooms, we were setting up telehealth visits through video platforms or through telephone. There were a certain number of patients where it's really challenging to connect with them for a variety of reasons. And for those, in those situations, we had to be innovative. And one of our approaches there was to have an on-site clinician, an on-site social worker who could go and meet with a patient rather than an individual-based model where I know all my patients. It was more of a team-based model, and I might meet with a patient in a consult room and bring in that social worker who knows that patient or that psychologist who knows that patient and bring them into the room via the laptop so we could have a three-way conversation. Additionally, when there are patients on site who have stressors, maybe getting some difficult news, having a complicated conversation, trying to figure out their treatment plan and make difficult decisions. And as was noted, with the no visitor policy, many of our patients were trying to manage these types of moments and experiences on their own. Now, granted, they may have their family member on the phone. They would try to bring them in. And while that works, it works well, but it isn't the same feeling of that person standing by your side and holding your hand, or sitting in the waiting room with you, or being there to debrief with you right after. So we know that we wanted to try to fill in that space as much as possible and do more outreach. And I'll describe a few of the ways that we did that outreach. Number one, I think at first we knew that we needed to put a lot of information up on our Dana-Farber website under our COVID-19 facts and resources, so that patients and their family members would have easy access to information about logistical things and practical things, but also some tip sheets and coping strategies that we really believe are going to be important for everyone to be thinking about, because this was a time like no other. And we wanted to be sure that we were providing what we thought was the best practice that was available to us to help people get through what some might consider a rather traumatic time. So we use those strategies and we put those up for patients' families. We also did, because we want to help our patients and families maximally, we also have to take care of ourselves. So we also set up sessions for staff. We provided coping tips, we provided drop-in sessions. And again, those were done not only on the outpatient side, but also on the inpatient side in close work with our Brigham colleagues. We do work very closely across the continuum with inpatient, and I think at the height of the pandemic, it was even more essential that we all work closely, especially for those patients who were not doing as well in the hospital and their family members were not able to be close by their side. So I think all in all, we worked particularly hard with our medical oncology teams, with our nursing colleagues, with our chaplaincy, and we knew that we needed to be more interconnected than we have ever been. One of the things I'd like to say about our international patients is that being very mindful of information that we were sharing, that this information needed to be translated. So it is accessible on the website in multiple languages. We do psychosocial distress screening, and the purpose of that is to do some early identification of those patients and their family members that may have more upfront needs and concerns, emotional well-being challenges or spiritual challenges, or concerns about their children. You know, how am I going to tell my 3 children who are 6, 10, and 12 that I have a cancer diagnosis? How am I going to talk to my family members about this? And all of that type of information we wanted to be accessible to our patients. In terms of cross-cultural work, we also were very mindful of, I would guess, say it this way, cultural humility. In other words, we don't know how everyone is experiencing this based on their own life and their values and what matters to them. And so I think we approach this very mindfully and carefully and with curiosity to try to understand how can we be most helpful to you and your family during this time. We also have an incredible number of amazing interpreters, I have to say, who worked day and night to provide support to our families and to our patients during this time. So I'll stop there, Eric, and I can add more as there are questions.
Thanks. So I'm going to make a few comments about medical care, and then I'm going to turn it back over to Ann to talk a little bit about nursing care, see if any of you have anything, and then open this up for questions. So I direct our breast cancer program, and I'm the Senior Vice President for Medical Affairs. And so my role in the Institute is really across all programs to some degree. And I'll speak to that, and certainly not just to breast cancer. One of the things we were concerned about very early on, of course, is that our therapies would potentially interact in a very negative way with COVID. And that by making patients immunocompromised as a result of chemotherapy, and moreover, patients with cancer tend to be immunocompromised even without chemotherapy. that patients would be more susceptible to COVID and might have a higher chance of dying from it. So with that in mind, we did a number of things really across the Institute. First, when it wasn't critical for someone to come see us and to be exposed to additional people having to leave their house, we immediately switched to telemedicine visits. And as Anne mentioned earlier, we had been doing no telemedicine. We used to have telephone calls with patients occasionally, but I wouldn't call that telemedicine. And in literally the course of about 2 weeks' time, we went from having virtually no telemedicine to seeing about 50% of our patients in that way. Obviously, we can't administer chemotherapy intravenously at home or by telemedicine. But we are able to have many, many visits. And I think what we quickly learned is that this was a very realistic way and effective way of taking care of our patients. Second, we thought very carefully about chemotherapy decisions. In many cases, where the decision about giving chemotherapy or not was somewhat borderline, we chose to go with a more conservative approach and avoid chemotherapy. We thought about ways in which we could use chemotherapy in a safer manner, at times opting for regimens that were less immunosuppressive, even if perhaps they had the potential to be ever so slightly less effective. These were things that we discussed with our patients. Our patients, of course, particularly early on in this, were terrified of getting chemotherapy. And we're often very, very open to these conversations. There were some other changes that occurred largely because of the need to conserve hospital resources. So for a period of about 2 months, all elective surgery was canceled. And during that time, for example, in the area of breast cancer, we had to come up with ways of restructuring treatment so that in a woman who might otherwise have had surgery first and then go on and receive additional medical therapy, we elected to reverse this and at times start her with, for example, hormonal therapy and then put off the surgery. Thankfully, surgery came online faster than expected, and we have had no problems since that point in time. As was mentioned earlier, I think by both Nancy and Anne, we were really concerned about keeping our teams together. Our physician and nursing and social work teams really work very closely with one another. We're used to seeing each other a lot. We're used to having a very strong multidisciplinary culture. And that breaks apart when you don't see people. And we bent over backwards to schedule more meetings at times than I think people could stand. But the interesting thing was everybody came to all the meetings. And I think it's because, most of them were working from home and they were very interested in making any contact that they could with their colleagues. I think the result of all of this is that we really have been able to provide safe and effective care. Our clinical trials slowed down but never stopped, and now they're up and running really in essentially full force. We're not back to normal. If you walk into Dana-Farber today, it looks like a very different place than it did 8 months ago. There isn't the hustle and bustle. We still don't have, to any significant degree, family members who are accompanying patients because of the need to maintain social distancing. But we're seeing almost the same number of patients that we did before. We're administering all treatments. And I think we're doing this, and at the same time, it feels for both patients and for those who work there to be a very safe place. Everyone is masked, and the staff are shielded, and the patients are masked. To the best of our knowledge, transmission between staff and patients has been something that has essentially not occurred. That's where we are. We're all hoping this is going to end soon. We all really want to get back to some semblance of normal, but normal will never be the normal that it was 8 months ago. I think we'll always have a little more telemedicine. I think we'll always have just a little bit more of a sense of caution around infection. Not that we were ever a place that ignored this as a cancer hospital, but I think that as much as people washed their hands in the past, that 2 years from now, they'll still be doing it twice as often as they did it a year ago. With that, I want to just go back to Anne and talk a little bit about the impact of all that has gone on the nursing staff. And in truth, the nurses are the one group of people who really, for the most part, couldn't do their work from home. You cannot be, and that particularly applies to the infusion room nurses, they can't do their work unless they're there face-to-face with patients. And I think that this was a particular challenge for them. We'll go to Anne, and then we'll see if anybody has any final comments before we open up to questions. Anne?
Yeah, thank you, Eric. So it is true, we had probably more nurses on site continuing to deliver care than other disciplines, which presented a number of challenges as we've all said, in keeping the team together, because it was often the nurse that right there with the patient and bringing in the social worker, bringing in the physician as needed as things were arising. Our nursing staff, as has been said, we've collaborated very closely with Boston Children's Hospital and the Brigham Women's Hospital for our inpatient oncology care. And because of the vulnerability of our cancer patients, we did have early on a number of patients diagnosed with COVID. So our oncology nurses on the inpatient service of Dana-Farber Hospital opened the first COVID unit that was opened inside the Brigham, and working with our colleagues at the Brigham. I think this is the area of care, although the outpatient care certainly represented and brought forward a number of challenges. But I think this these inpatient COVID units for nurses and really all clinicians presented just an immense challenge. And I think, these staff provided total care. There was no one else. The nursing staff were the staff that did all of the physical care for the patients. And so they were the liaison with the family. They would hold the phone to the ears of a dying patient so that the family could say their parting words to their loved one. They did a number of just incredible things to try to keep the dignity and humanity of the patients they were caring for, because often these patients came in and by the time they got to their unit, they were already intubated. There was no conversation. There was no ability to know that patient. And we in oncology care pride ourselves in knowing the patient and knowing the family. So they had family members sending photographs and put up images of the patients they were taking care of on the walls and the windows in the room, so that the teams caring for the patient would have some sense of who was this patient, they were taking care of. In the outpatient setting, the nursing staff, again, as Eric said, our patients were terrified of getting chemotherapy, but they were also terrified of not getting it. So they kept coming in. There was immense anxiety and worry, and yet they knew they needed to be there for treatment. So, so our nurses really were doing all they could to keep patients safe, bringing in all the other clinicians who were remote to the bedside as needed. And all the while, in the midst of all this PPE and all these barriers that keep us from touching patients and providing that kind of total care that's so important in oncology. I don't think it can be understated, and I guess if I'll just say my closing comments here, the impact of caring for these patients with COVID. I think this is a global concern of the emotional impact and ongoing toll that it has taken on our clinicians. We here in the US right now, it's fall, we're waiting for the onset of our normal influenza season, where many patients, and certainly our patients, are very vulnerable to that. We still have a lot of COVID in our environment. Here in Boston, we have over 100 colleges and universities, so all these students are back, and we are incredibly mindful of the potential for resurgence here, and really quite concerned about how can we support our staff through this, because they have already in the last 8 months experienced so much providing care to so many people who died alone, who just haven't done well. And as I said, this is not particular to us. I think this is a global concern. And so I think that is a key issue for us at the moment and going forward. We are hoping for the best. We have, as I said, great PPE. We have not had any patient-to-patient transmission of COVID. We have not had any staff-to-patient transmission, but we know that it's still in our environment, and we're entering into flu season. So we're not out of the woods. We have certainly benefited from the experiences of others around the world, and I hope that will continue, and appreciate forums like this where we can share our experiences.
Leslie, Nancy, any remarks before we open it up to questions?
I actually just want to say that in sort of coming off of what Anne is noting, and the impact on the staff and faculty and the hands-on clinicians, that sort of coming from our world in terms of psychosocial care, I think it's been really helpful for people to have some explanatory models for how to think about this and the impact on it, and what is this stressor, and to really to conceptualize it. And we have done this, I think, through educational forums and some of our support groups and other ways, but also to think about this is a trauma. People have experienced trauma, and in some cases have experienced great senses of loss, and that there's grieving going on, and that there's a way when you have a framework can set you up for strategies to how to address and manage this, because that's what we have to do. People have tremendous resilience in them, but we have to help them find their footing again and figure out a way forward. And I think one way in which we've done that as an institute is both through our through faculty and through staff, through our well-being office, through our integrative therapies center. We have held a number of forums for patients and for their family members, specifically addressing managing anxiety and stress through COVID. So I think some of these approaches are really helping set us up for what we hope will continue to get better, but also we know there are ways that we can do more outreach and stay connected, which is critical. So.
Thanks. Leslie, anything?
No, I think it just was, again, nice that we were trying to think about what maybe some of the positive messages were. And I think the persistent positive messages were that we absolutely have to work together as a team, and that pediatrics and adults are united in their desire to give the best cancer care possible, and that Boston and the Middle East is united in their desire to give the best cancer care possible. And the world really is global, and that there are good things about that, as well as some hard things like the pandemic.
Yeah. So we're happy to entertain any questions. We've got about 11 minutes, I think. If not, we can end it a little early. All right, so
before we leave, there seems to be one question on the chat. If anybody.
Oh, sure. Oh, I didn't see that. Sorry about that. Let me open it up.
About 9:47, I think. It came in, Eric.
Yeah, I'm just, I've now managed to lose everything. One sec. Do you want to read it and then we'll address it? Because I can't get to it at the moment.
All right, let me just see. Hold on.
I got a little.
Yeah, I can't get to the chat either, sorry.
Here, I've got it. I can do it.
Okay,
To what extent?
Now I'm back here. Okay, I got it. To what extent do your investigational drugs have the untoward consequence of oral sores in patients? 155 chemo drugs currently cause oral sores in 40% or more of patients, inhibiting their ability to receive hydration, nutrition, adequate nutrition and hydration. What strategies are you currently employing to mitigate oral sores, which account for 10% of hospital readmissions? So this is a major problem of a lot of chemotherapy drugs because of course they affect rapidly dividing cells, such as those in the oral mucosa, and it is a problem. We do a number of things that are specific to individual drugs to minimize this, ranging from steroid mouthwashes to the use of ice to decrease circulation in the oral mucosa, and a whole range of other approaches. The other thing, of course, is that in some cases, one has to simply reduce doses because of this problem. It can be not only one that interferes with nutrition and hydration, it can be really, really painful for a patient. So it is something we're very aware of. I'm wondering if Leslie wants to comment from a pediatric standpoint and perhaps from a nursing standpoint.
I can start. Yes, in bone marrow transplant, any full bone marrow transplant has really major problems with mouth sores, and as the questioner asked, it impacts nutrition, it impacts well-being, it impacts pain. There was an interesting study that's now going through the pediatric group that started from one of the adult oral surgeons at the Brigham and one of my colleagues, looking at low-dose ultraviolet therapy given to the outside of the mouth to promote healing. It's absolutely safe. There was some interesting data from a single-center pedi and adult trial, and now is going more broadly to the pediatric multi-institutional group, Children's Oncology Group. And so I think people are trying to protect the oral mucosa in as many ways as they can, and then use some non-toxic things to help healing as well. But it's another area which we've learned a lot from our adult colleagues.
Yeah, I don't have a lot to add there. I think, really good oral hygiene, and as you said, Eric, different kinds of rinses. Before you get to the steroids, just, salt water and things like that before it gets too bad. And frequent oral hygiene. I think some people have used topical numbing agents, but those don't really last that long. I think the ice you talk about can numb the the mucosa and relieve some of the pain, but it really is quite a challenge.
And it does vary from drug to drug, both in terms of severity and in terms of potential ways of getting around it.
I have one quick question, Eric, if I may. I'd just be curious to know what the incidence is in terms of pregnant women passing on COVID to their babies. Is that something that you can address?
I don't know that I can. My son is an obstetrician, but I don't have his brain in mine. Does anybody else know? Leslie, do you know? Yeah, I'm not aware. I'm sorry. I haven't heard of anything about that. You know, I have not heard anything about this.
All right. Well, thank you. It's just
I
curious.
apologize.
No worries. Thank you.
I'm not sure it's known, but exactly. I mean, babies can get it, but I'm not sure it's known if it's transmitted in childbirth or if they're acquiring it after birth. But this is way out of our specialty.
All right.
I know theoretically I could know because I'm a pediatrician, but I have not heard about it at all. So, which doesn't mean.
All right. Well, thank you very much. I thought it was a terrific panel and very interesting, and always one to look to learn as much as I can. And you've all enlightened me tremendously, so I appreciate it.
Thanks so much. All right. We appreciate you having us. Have a good rest of your
Thank you.
Okay.
Thank you.
Thank you.
Bye.
Bye.